This is an interview with Mr. Billy G. Griggs, who was the Senior Operations Officer for the Smallpox Eradication Program in West Africa. This interview is being conducted on July 7th, 2006, as a part of the 40th anniversary reunion for the launching of the program. The interviewer is Victoria Harden. Mr. Griggs, I would like to get a little background to set the stage as for your role in the smallpox program. I know you were born in Ripley, Tennessee on November 20th, 1933. Could you just briefly give me a little indication about your growing up years, your pre-college education, who influenced you, how you grew up?
Well, Ripley is the county seat. Actually, I was born in Ashport, which is on the Mississippi River, 15 miles west of Ripley. And in 1933, this was Boondocksville. Most of the things that came into Ashport came in by riverboat. It was a port on the river. Went to school in Ripley. Bus 15 miles to school. Was on a farm, of course. Rather uneventful in terms of typical farm boy's life. Did all sorts of activities going with farming. Went to high school in Ripley High School, graduated in 1951. Started at college my freshman year at Union University, which was a Baptist college, Jackson, Tennessee, about 45 miles east of Ripley. Influenced largely by the pastor at the church that happened to be located on the farm. It kept pestering me to come to Union. So I went to Union freshman year, met a senior girl, which was infatuated with. She finished that year and was teaching in Memphis, so I decided Memphis State was probably better than Union. We got married Christmas my sophomore year. I worked my way through college, working all sorts of jobs. Graduated in 5 years, coming out of school with a house, 2 kids, a wife, and no debt, I might add, which is very good for college years.
Certainly is.
Finished up the undergraduate work in January and decided to go on and do a master's in geography in Memphis State. Did the first semester. Was working at that point in time 48 hours a week at a soybean cottonseed oil mill at night. And after this lengthy time, I decided that maybe I better slow down just a little bit. And I knew there was a job opening down at the Shelby County Health Department for a VD investigator. So I went down to see about getting that, knowing that I could finish my graduate work there at Memphis State. And on arrival there, interviewed by Mr. Tom Davis, who was then in the VD program, found out that not only was there a state job open, but there was a federal job open called a co-op appointment. Same job exactly. The only thing was that the co-op required a 1-year training program and then subject to transfer over the U.S. So I say to myself, well, 1 year I'll finish this master's, and if I don't want to go, I don't have to go type deal. And besides, it paid $500 a year more money for the same work. Where you want to pick up?
I'm rolling now.
You're rolling, okay. You were telling me about joining the venereal disease program, and perhaps the tape stopped, and perhaps we should go back and let you start by telling me about the 2 choices you had, the state and the federal, and we'll pick up from there.
Okay. On arrival down at the health department, not only was there the state job, but there was a federal co-op job vacancy. And Tom Davis and Press Fish Tom from Atlanta and Press from the Nashville state office were there interviewing for the co-op job. And it was virtually the same job in terms of interviewing VD patients and locating their contacts and referring them in for treatment for venereal disease. The only difference in the two jobs was that the federal job paid $500 a year more than the state job, and at the end of a year you were subject to transfer throughout the United States. This was a cooperative appointment between the state of Tennessee and the federal government. Feds paid the salaries, and you worked literally as a state employee on a local level there in the city of Memphis. Keep in mind that my motivation for coming down was having gone through school at this point in time, working full-time work and making a living, and it was beginning to get a little tiring, so I decided that I probably ought to slow down a little bit and finish this master's degree. So I applied for the job, thinking that I'll just do a year at it and I'll have my master's and I'll get on with what I was planning on doing.
Which was?
At that point in time, I was still thinking possibly about law school, but some things had happened while I was working in a real estate company that I was manager of a rental department at one of the oldest and largest real estate companies there in Memphis, and going to school at night. I had several young lawyers that we had on retainer that were very smart, and they were having a tough time making a living, and I wasn't for sure that I wanted to do another 4 years of law school after the other. So that we started, applied, got the job, went to work. And there were 2 co-ops hired, I might add. Must have been, this was mid-June of '56. In early August, late July, Carl Hookings got a call, who was the director of VD there, that they needed one of the co-ops to go to the border, the Mexican border, to work with the Bracero program. There was a pilot project being run to see if the Braceros could be blood tested at the border, identified those that had positive blood, and then you could only have to follow up those scattered throughout the states when they went out.
And that would have been positive for syphilis only?
Syphilis only, because that was the blood test that was done at that time. They were checked for, in terms of visual, for syphilis and gonorrhea by a male nurse coming through. The other young co-op was,
thank you.
Excuse me,
That's okay.
I'll hold them down, was married, no children. I was married with 2 children, and he made a long pitch to Hookings why it really wasn't in his best interest to go to the border. And I didn't have any strong feelings. I thought it was going to be over by the time school started back. So went out to El Paso. The 2 kids stayed with their grandparents. Wife went with me. She was going to stay 2 weeks and then fly back and have the kids. She was a teacher there in Memphis. Well, we got there, and she decided that she didn't really like the idea because it was going to take longer than we thought, so we made a hurried trip back to Tennessee, got the kids, rented an apartment, one kind of an efficiency apartment, and started work. And believe me, in those days, things were a little different than nowadays working. The Braceros came across the border at 6 o'clock in the morning for crossing, went out to the reception center, and we started work. They were processed through, and that meant a complete physical in terms of looking at them, a chest x-ray, a blood test, since we were there to do this, and then they were checked and recruited by the farmers, processed, all of this, and then went to the farm that afternoon.
So the Braceros were the
agricultural workers, young male agricultural workers that were coming in for limited farm work. This day started at 6. It wound up, usually we were through about midnight that night. And it ran, the largest day of processing workers was 4,500 people that came through that kind of process all in one 24-hour period of time. We finished up in, must have been October, late September, October. And I returned to Memphis. The good thing about the Bracero program was Bill Watson, who was at that point in time the program management officer of the VD program, and I became quite good friends. I had, in the spring, had taken the Federal Service Entrance Exam and made fairly high marks on it, and got a lot of offers of jobs from other agencies at a considerably higher grade than the VD program co-op salary. And Bill and I talked about this, and then Bill had a long conversation with Johanna Stewart, who was in Washington at that point in time, and then Stu and I had a long conversation, and well, sum total of it was, by the time I got back to Memphis, I was processed through as a regular, instead of a co-op, I was now a GS5 as opposed to the normal GS7. GS5 stepped up grade off of the F-seat exam. And I used to kid Bill that at that time he was the longest co-op that had been, and I was the shortest co-op. I was converted in about 5 months. Returned to Memphis, stayed on at Memphis at the end of the year. We had a recruiting process started that second half of that first year and on into the second year, and I was, as a GS7, was the federal city rep in Memphis for the VD program, and recruited all over West Tennessee, Eastern Arkansas for people that we brought into Memphis, gave them a rapid training program in how to draw blood. They went to the interviewing school in Atlanta and then were transferred throughout the U.S. We hired some 50 people that second year there in Memphis.
How did you decide who was going to work out and who wasn't? Did you talk to each person?
I interviewed I was the major interviewer at that point in time. There was not a central interviewing team that developed later within VD for the large-scale interviewing, but we visited colleges, had an ad in the paper, and interviewed people, and tried to pick people who were, I would say, resourceful, self-starting, understood kind of what they were getting into, and so I spent that second year as the city rep in Memphis from that, and then in the summer of the second year, the pilot project had been very successful on the border, and I went back to El Paso, which was the headquarters of the border program covering all of the border, and we had another assignee in Southern California, assignee in Hidalgo, Texas, and I covered the Nogales, Arizona, and the El Paso station out of El Paso. And that was my first real exposure to international. We visited down in Mexico at the reception centers in Mexico. They had 3 places where they checked it, the overall health of the workers before they came to the border.
Well, and this experience is what made you the logical person, I suppose, to be coordinator for the International Symposium on Syphilis and other I'll not say it right.
Treponematosis.
Thank you. In 1960 and 61.
Right.
This was bringing together people from all over the world then, or the Western Hemisphere?
Well, it was worldwide. There were about 1,500 people at the symposium in Washington, D.C. at the Sheridan Park from some 65 or 70 countries. It was a large meeting, probably a first-class meeting with translation in French and Spanish, as well as English version. Lots of papers, a lot of coordination in terms of getting the people together, letters out for the invited speakers, establishing everything that goes along with a meeting of that size. I had left El Paso and gone to Houston as a city rep in Houston, came from Houston to Atlanta. When I was interviewed for this job as the coordinator of that, I was kind of offered the opportunity to live in Washington and commute to Atlanta. The VD program had moved from Washington to Atlanta in '57, or live in Atlanta and spend a lot of time commuting to Washington and New York. The other sponsor of the program was the American Social Health Association in New York City. And Atlanta being a much better place to live than Washington, that wasn't much of a problem. It was a supposedly temporary assignment here for 22 months to hold that. At the end of that particular assignment, I went into back into the VD program at headquarters as the Assistant Chief of Operations and Development, with responsibility for the grant program in terms of working with the states and the major cities in submitting and approving VD control grants. That was a couple of years in that. By now we're up to late '64. Got a call from Bill Watson one day and said there's going to be probably a program in terms of smallpox and measles control with AID sponsorship and funding that D.A. Henderson is putting together, getting started, ready to put together. And I'd like for you to go over and talk to D.A. about being the program management officer and deputy of that program. So I went over and talked to D.A.
And I understand that you had to do some selling about how to structure the personnel for this program.
D.A. came out of the EPI program, and while he had some exposure to public health advisors, he had not really worked very closely with public health advisors at that time. And it was some structure to sell the business of a joint effort with a MD epidemiologist and an operations officer, because it was from having experience in Mexico and other sorts of things. It clearly was going to be a program of operations, not one of technical.
This is very important. Would you talk a little more and define what a public health advisor, what he did, how he was trained, and operations officer? Are they the same thing, slightly different?
Operations officer's title was created for Africa because public health advisor is the series that the people were in the U.S. in the civil service group. But the operations officer kind of was more descriptive for the African people than a public health advisor, because one, it clearly understood that these guys were advisors, but they were operationally involved. I think that just like in the public health advisors in the U.S., they worked with local health departments or state health departments or regional office, but they were pretty much had the understanding and expectation that they were responsible for getting the job done. And I think, generally speaking, it was a situation in which not we can't do it, but how can we do it? In other words, if it's need something else, what do you need to get it done? And they started out working in as just interviewing and running down contacts, and then moved up to supervisory positions, grant writing. In some instances, they were literally functioning as a VD control officer in some places. So it was a multi-task, multifaceted background and job. Might add that growing up on a farm didn't hurt this any either, because it was all of the kinds of things that you have to do in getting jobs done there worked out. And digress for 1 second, we had a problem out in El Paso in terms of the quarantine who was running the public health aspects. When we got there with 4 people, where are the other 20? And this is it. And well, you really, you can't slow us down. We've got to run these people through at this speed of time. So we had to work out a system that would let you, with 4 federal employees and a couple of local hires, handle that drawing bloods and processing the specimen and getting shipped to Austin to get the results back. And so there was a lot of that kind of thing that came along.
So when you convinced Dr. Henderson that to have operations officers in the smallpox program, what was the next step then? Did you have to go out and hire people?
Well,
how did it go?
we started. I started with DA probably in November. At that point in time, it was a kind of a expectation that there was going to be a program. There was no project agreement signed with any country in Africa. There was no project proposal. That we were in the process of writing that this was to be a 19 country program, and would require an agreement with each of the ministers of health of that country between the U.S. government and that to do the program. And so while we were writing all of this up in terms of the proposal that went to aid and was then subsequently carried over to the countries and negotiated, we were developing a needs for material, vaccines, people, the whole bit, so it was all going along at the same time. I think DA came around relatively quickly to understanding the need for the operations officers. He and Henry Gelfand, who was one of the other physicians in the office at that point in time, did a fair amount of interviewing of physicians, and we were looking not only within the incoming EIS type people, since we had the opportunity to get the young docs coming out is serving their draft time like the other commission corps, but we were looking outside of commission corps and hiring some people who were not coming through that, and might add some very outstanding physicians. Don Hopkins, whom the name I'm sure will crop up in this repeatedly, was an individual that was hired as a physician from outside of the EIS or anything, so it was a direct hire, and several other physicians in this, some older physicians that went overseas. And the model was to have, in most countries, a physician, epidemiologist, and an operations officer. In a few of the smaller countries, the physician epidemiologist served two countries with an operations officer in each country. In Nigeria, because of its size and complexity, in addition to the headquarters office in Lagos.
My understanding is that there was an awful lot of details regarding the equipment that had to be used in the project. You had to deal with trucks, with doing a procurement for trucks that were U.S.-made trucks, how to rig them up to have refrigerators for measles vaccine. And can you tell me about what all you had to do at this time from that standpoint?
Well, we had the benefit of a little bit of history of this. To backtrack 1 second, if someone hadn't mentioned before, it needs to get into your program somewhere. When measles vaccine was first in the process of development at NIH, the Minister of Health from Upper Volta came over on one of the leadership grant visits and was out at the thing and was being shown the measles vaccine, and said measles is a major killer of children in my country, and I would like to offer my country as a place to field test the measles vaccine for you. So in '63 or thereabouts, the USAID signed a project agreement with Upper Volta to go out and do several 100,000 measles immunizations. CDC was asked to provide an EIS officer to be an advisor in the field for this team. USAID provided some trucks and petajets to use it with, and then Merck, who had the measles vaccine, provided the unlicensed vaccine, and the program went to Upper Volta. The first year it was more successful than expected. I think they did about 700,000 of these. The next year the measles incidence in Upper Volta just dropped off to practically nothing. So the surrounding countries said we would like to have a measles program, and USAID was negotiating to do that, and they asked for 3 or 4 EIS officers, and the program was expanded to the 2 or 3 countries there. Then the year that reason the smallpox program actually came into existence, AID had come back to CDC and said we would like to have a major measles program, and we need 20 EIS officers to be assignees to work with these countries on doing this. And DA picked up on this and said measles is going to be an never-ending problem. I should have added it the second year when they did not do the program in Upper Volta. The second year did the surrounding countries. The third year Upper Volta measles right back where it started to start with. So it was known early that in order to be successful in measles, it was going to require a fast-hitting, multiple repeat, because the birth rate was so high that you built a new supply of susceptibles each year. So DA proposed the business of adding smallpox eradication to this. As far as West and Central Africa was concerned, it had been it come up in WHO about pushing for a global smallpox eradication program, and this was going to be probably the toughest part of the world to try to do it in, and so that was proposed for a 19 country program, starting at Mauritania and going all the way around to then Congo and over to Chad and Central African Republic, the whole West and Central Africa. That AID would consider doing, and we were putting together this proposal as to what it was going to cost for this, and this was the project agreement proposal that I was talking about. And in that you had to, based on what information was available from the old measles program, what kinds of vehicles are going to be required for each country, what kinds of vaccine, how much refrigeration space, the whole bit. And this was all calculated into this project agreement for each individual country. Sum totaled up to a $46 million 10-year, 5-year eradication program for smallpox and control of measles in the 19 West and Central African countries. Subsequently, the other 20th country was added, which was Fernando Po and the island of whatever, to make it a 20 country to cover out that whole area. So there was a best guess as to needs based on the life expectancy of the trucks in terms of a replacement on a 2-year basis, the life expectancy of the petajets, and the requirement for all of the petajet is an instrument that is foot operated hydraulic to give a hydraulic injection of the vaccine only. All of this was listed by country, and as I said, put together for the full amount of the 20 countries. Started with 16 countries the first year. Second year was to be the 3 countries, Sierra Leone, Guinea, and Liberia. And then, of course, the 20th country was added that third year in it.
When you had to estimate the life expectancy and plan for the budget, were you correct? Did they last that long, or longer, or not?
Well, we had some problems with vehicles that had not been expected. The Dodge truck was not selected as the vehicle. It was the vehicle that was chosen by bid. We looked at both Dodge, GMC, and Ford, and Dodge won the bid on it, and it was an eminently suitable vehicle. I was familiar with Dodge and was pleased that they won the bid, but we ran into the difficulties with the roads, and this truck being a long bed crew cab had a lot of weight on the 2 axles, so a lot of axles were broken in Africa. And while we sent over with each truck and each year sent over a the best guess as what was going to be needed for repair replacements to keep the vehicles running, it soon became apparent that you needed something that would provide a rapid turnaround on emergency, because a vehicle was down, everything came to a stop. So we negotiated with a local Dodge dealer a parts replacement general contract on a task order that you just order what you needed type thing, and air freighted them to Africa. And we had get a cable in that got to have this, and it was that day it was ordered and put on an air freight shipment, and it was usually in Africa in a matter of a week, 10 days.
And who actually did the replacement of the part? Was this part of the operations officer? I know they had a training in.
Operations officer, and part of when I'm getting ahead of myself a little bit. Going back to we were doing all of this in the spring in terms of writing these agreements. We had people actually starting in late spring. Henry Gelfand and George Lithcott, who had been selected. He was a doctor working on a program in Ghana from NIH as the director for the regional office to be established in Lagos. And I think Mike Lane and a couple of other people were visiting the countries, negotiating project agreements, explaining the program, moving towards getting signatures. We were also, after the participating agency service agreement had been signed with AID, and it was a pretty sure bet that we were going forward with this, started recruiting people and starting security clearances on doctors and operations officers to report to Atlanta the 1st of July for to go through the EIS course that was the normal training for that period, and then to stay on for an additional training course in smallpox activities, in which there was, for the operations officers, a more lengthy, and even for the medical officers, a shorter version of a mechanics course to learn all about these Dodge vehicles and repair on them and what needed to be done. Now, keep in mind that the repair of them was a responsibility of the host country. I mean, their facilities, their mechanics, supposedly, and they had some exposure to Dodges, but not a lot. But the Dodge turned out to be a very good vehicle. I was last in Africa shortly after retirement in 1989 in Togo, and I saw 2 of the Dodge trucks that had been there. The last one was sent to Africa in probably 70, may have been 71, and in 89, 2 of them that I saw out in the field were still running.
Let's talk about going to Africa. You had to help all these people get settled in all these different countries, being the headquarters operation. How did it work? So that
well, after the decision was made to have a regional office in Lagos, we were going to send 9 people there. We had a young, not brand new EIS officer. I'll have to put a weight on him to hold him down. EIS officer that was going to be the epidemiologist. George Lithcott was going to be the director of that. Jim Hicks, a senior public health advisor, was going over as the administrative officer. Bill Dupre was assistant administrative officer. We had a U.S. secretary, Gordon Robbins as a health educator. Nat Rothstein as a virologist was going to be there primarily to work with the vaccine production facility and develop a creditable one there in Lagos to make vaccine, smallpox vaccine. And a statistician, Davis, drawing a blank on his first name. So 9 people there, and they were to provide a nucleus of expertise that they could be more rapidly get from Lagos to the surrounding countries in those various areas, statistics or more senior epidemiology or administrative function or whatnot, rather than trying to put all of that kind of expertise either from here over or in each of the countries. I first went to Africa in the summer of '66 with responsibility for working with the Department of State, Embassy, and aid in terms of lining up office space and housing space for that regional office people. We located offices, prevailed upon aid to sign the contracts for the offices and houses. So the regional offices were worked out. In each of the countries, that was kind of left up to either the aid officer. In many of these countries, there was not much of an aid activity. Much of this of the smaller countries, the aid was provided out of a activity out of Washington called the regional office, which kind of had the responsibility for several of these smaller countries. So really, all of the administrative sort of activities were handled by the embassy on an agreement between aid and the embassy in those countries. Our people going over, the office space was the responsibility of the host country, and they actually had an office in the Ministry of Health or in an appropriate health building with the Ministry of Health. And the housing was provided by the U.S. Embassy, or through the U.S. Embassy on a contract basis.
And that worked out okay.
Worked out fine.
With the people. In 1966, D.A. Henderson moved to the World Health Organization, to Geneva, at least I think it's 66, and Don Millar came back from London to take over.
Don had been in getting at the London School of Tropical Medicine, getting a degree, and came home in the summer of '66. In other words, Don was missing during most of the preparation for the smallpox program, and he got back just as we were getting folks to start.
And I have a quote here that you said to him, "Welcome to the NFL." You want to explain that and talk about how it was to shift from one leader to the other leader in this case?
Well, Don and D.A. had a considerably different management philosophy, I guess you would say. Don was, I didn't know Don. As a matter of fact, I may have met Don, but I had not remembered meeting Don until he showed up at the office coming back from England. We hit it off quite well. Don was, I guess, was completely unexposed to operations officers or public health advisors, but he quickly saw the value of this and was a champion of the public health advisor throughout the remainder of his career, even after he got into NIH. This. So Don came in. The program was moving right along in terms of the training activities. Project agreement signings were slow. We were ready to, had planned on sending the first people to Africa in September, and time to get there to get things kind of on the road at the end of the rainy season to be ready to start at the beginning of the dry season. The last PROAG, I think, was signed in March. So you can see there was
March of '67.
March of '67. There was a considerable delays in getting all of these, and there was some very fancy footwork that was done in getting PROAGs assigned. It's too bad that George Lithgott's not here. George was I guess you would say he was a master at getting things done in Africa. I won't say how, but he wound up getting an appointment with the, I'm not sure what the title was. He wasn't president, the head of the government of Nigeria at the time after the coup. Anyway, he got an appointment with him and got a commitment that it would be signed, and it was signed. That was the big one, with the regional office going into Nigeria and the 3 or 4 regional assignments within Nigeria. And because of its size and complexity, northern Nigeria had a medical officer, and 2 operations officers. Had a male and a female operations officer. The only female operations officer we had, because of the expected difficulty of working with PERTA in terms of getting the women vaccinated, and it worked out quite well.
And what was her name?
Vicki Jones.
Okay. Were there any unusual occurrences that you think of that you can tell me about?
I hope you can think of some of them to trigger my mind on them. There were so many things that were happening. We had some problems with one individual I recall that had difficulty with a security clearance and never got it cleared, so he was very unhappy. The people that were sitting in Atlanta with families and living in temporary quarters and being delayed about going overseas were considerably unhappy.
And this was all coming back to your desk?
Mine and Don's coming to, if it was a doc, he would go to Don, and Don would come to me. If it was an operations officer, he'd come to me, and then we'd try to get this resolved. Don and I went to Nigeria. I'm losing track of time. The program had started, people were there, and it was a meeting, and the folks that were in Africa came to it, and there was a considerable less than happy campers, I guess is a good way to describe it, over a variety of reasons. Some of the people that had been hired during the training session, we had an introduction to the for the cross-cultural problems they were going to be facing, and trying to give some insight into the things, the do's and don'ts, or at least think twice before you do type deal. And I remember very vividly, one of the wives was aghast at the thought of having a cook, a nanny for the kids, a gardener, and a night watch person, which were the typical family local hire people, and maybe a small boy for the kitchen, if depending on how many kids they had. And she was, don't want that. And then when she got to Africa, since they had no kids, we lived by the ground rules that the American Embassy had, and it said no children, where it usually put in flats and apartments, so single people were put in apartments. If possible, families with children were given a house with a yard type deal. So when we got to Yaoundé, she was very unhappy because she was in an apartment when other folks had houses. So the uptightness about the ugly American with hiring the people and going to the market and sending the local hire to the market to buy food and whatnot, and not shopping for themselves, soon became a thing of the past. People realized that they just couldn't, the American could not cope with that kind of activity.
Very interesting. What was the toughest problem that you recall in this whole endeavor?
Oh, I hadn't even thought about that. I guess the one that caused the most consternation was the delays in getting project agreements and getting people out there ready to go.
So the beginning was, once it was going, it was...
We had difficulty of, as you can imagine, people have a tendency to look at, if they really think they're going to, they have a program that says we're going to do 300,000 vaccinations. So they want 400,000 doses of the vaccine, because they're going to have some loss at the end of the day. The vaccine that's opened is discarded at the end of the day. So they ordered more vaccine than they needed, or didn't order enough vaccine, and it was a problem of trying to second guess people in the field, or respond back and forth to people in the field about what the realities of the program are. About you got to have the vaccine. You have to discard it if it's at the end of the day. But if it's only 2 people left and you're going to be there in the morning, if they're locals, you don't necessarily open a large vial of vaccine to throw away, type deal. So it was in the business of getting the parts. It's never, and having been in the field myself, it's never fast enough. How come I didn't get it yesterday? Is the attitude type deal. So there was a certain amount of confusion and consternation constantly on this. But the program was, as I told you to start with, had a budgeted cost of $46 million, largely through some good work on the contract officer on making contracts, largely on the business of being innovative and looking at alternative sources for things, and the business of the reduced amount of vaccine that was wasted and lost. It was completed at a cost of just over $30 million, so at $16 million under cost, and was completed in West and Central Africa a year ahead of schedule in terms of smallpox eradication. So
that is an amazing story. I really think. Tell me about the bureaucratic relations between headquarters in Atlanta and the regional office in Nigeria, in Lagos.
Sore point. The regional office was designed to start off to be a resource of experts to be available for the countries. George, maybe from the first, I'm not for sure. I wasn't involved in recruiting George. I don't know what was said to him. George felt like that the regional office was the direction, and Atlanta was the staff work to provide office to the region. This was resolved, I think, amicably. George stayed through to the program, and I think he was satisfied. He would have much preferred to have been running the program, but I don't know how to say much more about it than that. Copies of things went to the regional office so that they were aware of what was going on, but it did not go through the regional office to be signed off on. Dave just walked in, and I'm sure that he may have a different story about this regional office conflict, but it was resolved. People were not ecstatic over the way it was resolved, but the program operated.
If you were going to undertake the program again, would you do anything differently?
Knowing what I know right now, I might do something differently. Not a lot. We didn't, and I'm not saying this doesn't sound right coming from me. We didn't make a lot of mistakes in the smallpox program. Things were thought out, were worked out, and the recruiting. We had a couple of people that I might not have recruited, but we didn't bring anybody home for improper action or not doing their job. And to have had 46 people in the field at one time, and overall, I've not even looked at the number, but probably replacements, probably 60, 70 people overseas, and not to have somebody that we had a medical evacuee now, but I'm talking about to bring somebody home for either unable to carry out the work or the host country saying, get this guy out of here.
That's also very impressive, is it not? Did you ever have any doubts that the program was going to be a success?
No. None. After it got off the ground. Smallpox, success in terms of smallpox eradication, success in terms of measles control, it was an awful lot of people thought it couldn't be done. It was proven that it could be done with the right kind of input. Gambia, with Bob Helmholtz running Gambia out of Senegal, and Tom Leonard doubled with Bob in Senegal for a short period of time. Tom was in Mauritania, and through the, I guess that was the 68 conflict or whatever it was, the U.S. government left Mauritania. So Tom went in and finished his tour in Senegal, but the Gambia had a good person that was in charge of the program, had a minister of health that was very much in favor of this. Small enough country, and while it had poor roads, it had a river that ran through the middle of it, and you could get up and down the river. And the Gambia interrupted measles vaccine, measles transmission in the country, and kept it measles free for a couple of years. So it could be done, but it required an awful lot of effort, and I don't think Africa was ready for that effort wide, but smallpox was.
How did you all in headquarters deal with the feedback you were getting in terms of your conversations, the feedback from the people on the ground, and what you then fed back to them?
Well, there was a weekly newsletter that went out to all the field staff that was kind of a folksy.
And that originated in Atlanta?
Originated in Atlanta. And Don dictated this, and it was some added to it from me, and this was just kind of what's going on, what the problems are, what some solutions to problems. Lots of phone conversations, and after a phone conversation in those days, you went to West Africa, French West Africa through Paris, and English West Africa through London, with a radio call from there on down. So you started out with a voice that they should hear you at least 2 floors above you to build up a impedance on the radio, and after a long conversation, you almost lost your voice sometimes.
What do you think that the Africans learned about the CDC and about America from this program?
Some of them already had exposure to CDC. There had been EIS officers in with the measles program a little bit earlier, but I would say that in terms of philosophy, the operations officers were told and tried to get them to establish that your responsibility is to get the job done, but it's not to do it. If you do it, if you're out on vacation or out on leave or out sick, things are going to go to hell in a handbasket quickly. So while it's much more difficult to train your counterpart to do the work, it's worth the effort if you want something left when you are not there that can go. And you could very quickly see the difference when this philosophy was accepted and followed through on, as opposed when it was done directly by the operations officer.
So that was a legacy then that was left.
That was a legacy that was left.
Program was over.
We brought from Africa to each of the training programs each year a cadre of docs and nurses. Now, Africa had a few docs, but most of the actual field activities of the program were carried out by nurses, or kind of an African operations officer, if you want to call them that. So there was a group of those that came to Atlanta each summer, and I don't have any idea at the number. Probably over the 5 years, I would say there was at least 100 people that were here and participated in the training program. The residual of the smallpox program in Africa, after it the last year was 71. The program was, at the end of the time, the people were brought home. Aid wanted to follow on with the program, and it was a program that was childhood immunizable diseases, which subsequently came to Atlanta, to CDC through a participating agency service agreement. And the activities, the countries that were involved in this were virtually the same as the smallpox program, with some expansion into East and Southern Africa for some activities of that. So all in all, I would think that from a standpoint of the foreign relations, the smallpox program was forget about the health aspects of it. The money spent in smallpox program was probably is better or equal to anything that was spent otherwise. In the 20 countries, I can't give you a number. There were a lot of coups and counter coups and changes of government. A civil war in Nigeria, right in the middle of starting the program, and no one was evacuated except the team that was in eastern Nigeria was brought out. But in terms of a coup and a change of government, the smallpox and measles program proceeded as if nothing had happened.
I have just a few more questions here. What impact did the program have on your career?
Hard to say. I guess it was probably good. Dave Sencer came in as the director of CDC during the program, and I could have said this better if he wasn't in here, but I'm going to say it anyway. We, the smallpox program, were accused of being Dave Sencer's pets and fair-haired boys. But I might add that when Don and I, or subsequently after Don, when Bill Fagey and I went to Dave and laid out what we needed, Dave bent over backwards and gave us what we needed to the extent possible, and it was sufficient.
Did this impact, did this program have any impact on your family? Now, you were here in Atlanta primarily, visiting after you weren't living, but how did your family think about it, just to get personal?
I had a good wife who understood being gone 3 weeks at a time. George Lithgott tried his damnedest to recruit me to go to Africa at the regional office, and I turned him down. And obviously he had talked to DA and maybe to Dave, and I think they turned him down. Other than being away from home a short period of time, but while I was in VD, I was home on weekends. But I traveled more days when I was working the 50 states than I did when I was working in Africa.
Did any of your children go into health-related work?
No.
Not a one?
Not a one. As a matter of fact, my son may have had a negative impact of this. He was, I think, pleased with the work that I was doing, but he was adamant that he did not want to work for the government. I don't know who brainwashed him.
Very interesting. Is there anything else you think of about the program that we should capture in this interview before we stop?
Well, I'm sure that Don Millar and others will say it better than I would, but the things that were really learned about doing work, immunization work, in this country as well as other countries from the smallpox program have made a big impact on, I think, the U.S. Activities and as well as the international activities in other countries. Obviously, DA was head of the smallpox program in Geneva. West and Central Africa cleared up right quickly. It was obvious that some problems were occurring in India and Bangladesh and other sorts of countries. CDC people from the West Africa program went overseas into many of those countries to either get kick-started and get started, or to stay there and wind up in Bangladesh, India. Andy Eagle was in Afghanistan, so it was a maturing of CDC's international venture, I think, and it expanded in terms of while CDC is a domestic organization. When I left CDC, we had people assigned in probably 25 or 30 countries around the world through WHO or through other avenues, the World Bank, UNICEF, etc. And this has contributed, in my estimation, immeasurably to what health activities. I think the Gates Foundation work in international health goes back to the smallpox. Bill Griggs was a missionary in eastern Nigeria, and I guess was happy when we recruited him to be a contract doc for eastern Nigeria for us. And when he was evacuated, we brought him back here, and he became one of the lead people in smallpox. And when Don left, Bill, of course, became the director. Went back to India for the wipe up on that, and I'm sure, no question in my mind, that the Bill Gates Foundation would not be doing what it's doing if it were not for Bill Griggs.
Very interesting. Thank you so much for speaking with me, and we will stop the tape.